Thank you for inviting me to talk about clot management. Clot management is often like fighting your enemy. And for that, I would like to share with you an old Asian wisdom, which is written more than 2,000 years ago in this so-called Bible of War at that time. It mentioned that we have to evaluate our enemy's strength in order to decide on various strategies, including to surround, to attack on one end, or to evade or to avoid on the other end. So this is a patient with inferior myocardial infarction, with VF in the emergency room, successfully resuscitated, bradycardia, hypotension, supported by dopamine and pacing. We can see a tactic RCA with thrombotic occlusion at the mid-RCA. Notably, this RCA also supplies LAD territory, as there is an osteo-LAD CTO. So after wiring, we see some flow, and we also see a sizable thrombus. So we started our battle by attack, first using manual thromboaspiration, but it didn't work. So we escalate our strategy to surround and attack. A surround, we give 2B3 inhibitor, and by attack, we escalate to penumbra aspiration. And after some time of 2B3 infusion and also a few runs of penumbra, we successfully regain the flow, and we can see some filling defect like digital thrombus that can also be due to flow. We gently dilate the lesion and confirming that there is a large thrombus here. So we give another one run of penumbra aspiration, and angiographically it improves. But still, there is some filling defect here, again, either due to the flow itself or due to thrombus. So we evaluate the strength of the enemy by IVUS, and it confirmed that there are layers of thrombus distally, and more worrying is there is a mobile floating thrombus at this region. So because of the foreseeable risk of distal no reflow and also instant thrombosis, we decided to shift our strategy to avoid. By that, we mean deferred stenting. We keep the patient on 2B3A inhibitor, and then we insert an IBP. But the battle continued when the patient deteriorates about 12 hours later. It required escalating dose of inotropes and echoes deterioration in cardiac function in both RCA and LAD territory. We brought him back, and this is the angio. Actually, on comparing with the previous angio, the flow is slightly improved, and also the thrombus seems to be slightly resolved while the patient is on 2B3A. But since the clinical profile suggested that the patient had ongoing ischemia in RCA and LAD territory, we have to proceed with the stenting. We first assess by IVUS, assessing the segment with stenosis and also with a thrombus. And we can also see that the RCA is atactic with about 7 millimeters in diameter. So we decided to put in an undersized 5 millimeter stent with a landing zone here. So we predilate again 2.5, confirming the flow, and then put in a 5.0 stent. But the unfortunate thing happened. There's no reflow. And a distal injection with fullback showed that there is both distal no reflow and also thrombus and instant thrombus here. So we promptly escalate our treatment by more surround and more attack. By more surround, we gave IC TNK. We gave repeated bolus of IC adenosine, and at one time we gave IC adrenaline. And for attack, we used angiojack this time for a few runs. Unfortunately, all these measures didn't work. Although by distal injection, we can see that the thrombus has resolved, but now we are facing a refractory no reflow. And the patient is deteriorating in terms of hemodynamic. So at this point, we think we have to prepare for evade. We want to keep the best shape of our fighter, of our patient, and allowing best chance of survival. So we set up a VA ECMO for hemodynamic support. And after the last trial of adenosine angiogram, we leave the patient on VA ECMO, IPP, and inotropes, hoping that it will buy time for patient recovery. And the patient did recover. The next day, he improved in hemodynamic, and he was able to tail down inotropes with improvement of airway ejection fraction. The ECMO could be weaned on day 3, and IPP could be weaned another 2 days later. This is a result decoronary angiogram showing aesthetic, widely patent RCA, and also with collateral to the LAD. Recovery can also be reflected on echo. In the upper panel, the echo was performed on the day of deterioration. You can see a poor ejection fraction. And echo before discharge show a recovery of the airway function, notably over the LAD territory. This is another echo view, again showing a recovery of airway function with a recovery of the septal region in the LAD territory. So in summary, we have various strategies for fighting a battle, and we need to apply these strategies in addition to PCI tools to fight clot. We have to prepare to attack using manual aspiration, penumbra, angiojack, etc. We have to prepare to surround using TUB-3A, and sometimes we need IC lytic. We need to be ready to avoid, if needed, by deferred standing. And at times, we have to accept that we have to evade. And at that juncture, we have to keep the best shape of our fighters, of our patients, by using appropriate hemodynamic support, which allow some time for patient recovery in terms of flow and also in terms of cardiac function. Thank you very much.